Thanks to all of you for tuning in. We'd really hope to be doing this event in person today, but in order to make sure that everyone felt comfortable and to make sure we're being as careful as possible, we have shifted to this virtual format. We are still certain that it will be a great and thought-provoking discussion. We are honored to have a great lineup of hospital and health system leaders with us today. I am thrilled to introduce Dr. Sue Turney, CEO of Marshfield Clinic Health System, Dr. Imran Andrabi, CEO of ThedaCare, Eric Conley, President of Froedtert Hospital, and Bernie Sherry, Market CEO for Ascension, Wisconsin. Before we get started, I want to make sure we thank our very generous sponsors of the Wisconsin Health News Newsmaker series. These important discussions would not be possible without their support. So a huge thank you to Anthem Blue Cross and Blue Shield of Wisconsin, Deloitte, Froedtert and the Medical College of Wisconsin, Husch Blackwell, UnitedHealthcare Community Plan, Briesen Roper, and the Wisconsin Hospital Association. Thank you also to Badger Bay Management for helping host today's event in partnership with Wisconsin Health News. Wisconsin Health News is an online, nonpartisan news service. In addition to hosting events like these, we also publish a daily email newsletter. If you are not yet a subscriber, I encourage you to sign up for a free trial. You can sign up on our website at wisconsinhealthnews.com or through the event evaluation, which we'll email out after today's event. An extra thanks today to Froedtert and the Medical College of Wisconsin, today's featured sponsor. We are very grateful for all of their very generous support. Eric Conley is providing double duty for us today. He will also be delivering the sponsor remarks. So Eric, take it away.
Thank you, Tim. So on behalf of Froedtert and the Medical College of Wisconsin Network, I want to welcome you to the Wisconsin Health News Hospital CEO panel. First, I want to thank Wisconsin Health News for providing all of us together again, for getting all of us together again during a critical inflection point within our community. As healthcare and business leaders, and as a community, we've had to pivot over the past 2 years. Time and time again, our community is to move it forward. I'm proud to say that each of the organizations represented here today has continued to show unwavering commitment to all of our patients and the community during this challenging year, these challenging 2 years. With respect to that commitment, we need your help. All of our hospitals are critically strained right now, which in some cases is preventing care for others that are in need. Unfortunately, the vast majority of our COVID-19 admissions are patients that are unvaccinated and could have prevented their need for care if they had taken action during this pandemic, earlier during this pandemic. I wouldn't be doing my job if I didn't advocate for the COVID-19 vaccine and its booster, as they have proven to be the safest and most effective way to prevent and lessen the severity of COVID-19. Time and time again, we've proven that if we move forward together, we can be stronger and better as a healthcare and business community. So on behalf of Froedtert and the Medical College of Wisconsin Health Network, I want to thank all of our providers and staff at each of our organizations for their tireless efforts to keep all of us healthy and safe. While we still have a long way to go, it's these providers and staff that will help us get back better. Thank you.
Well, thank you, Eric, and thanks again to Froedtert and the Medical College of Wisconsin for all of your generous support. And thanks again to our hospital and health system leaders for being here with us today and sharing some of their valuable time. We have a lot to talk about, so I'm just going to dive into the questions. And Dr. Andrabi, let's start with you. A top topic on a lot of minds right now is Omicron and what this new COVID-19 variant means. What do we know so far? And what is ThedaCare doing to brace for its potential impact?
Yeah, thank you. And it's a pleasure to be with all the great panelists. And thank you for having me here. It's been a journey, 650 days and counting. And we've now been through multiple surges, if you may. Watching what's happening with Omicron, with news coming out of South Africa and some of the work that's happening within the US as well, and the spread of the virus across multiple states. A lot of information in terms of, its transmissibility and what does that look like? Is it going to be as severe as the Delta variant or other variants that have come before that? So that's another question that's being looked at. And then what's the impact of the vaccines and the boosters from an immunity perspective against the Omicron virus as well? So a couple of things that we have been doing and continue to do is we actually had a group of people within our organization that have been modeling the COVID-19 virus from the very beginning. So how does it act? What's the transmissibility rate? What do we expect so that we can sort of be proactive in understanding, what are we going to see in terms of positive cases? What are we going to see in terms of numbers of hospitalization? And unfortunately, there's been a significant number of people that have lost their lives in this process as well. So watching all of that and taking that into account from an Omicron perspective as well in doing that modeling so we can stay ahead of it and make sure that we are doing what needs to be done. But having said that, I think, as was said earlier, there are a couple of things that we already know. So despite whether it's Omicron or it's Delta or it's anything else, we know that the COVID vaccine is a good way to go down the path of and get your initial, first and second doses, depending on what vaccine you're taking. We know that the boosters boost your immunity. And, right now, the information that we have is that, it does have enough immunity to take care of the Omicron virus as well until we have more data. We know that masking works, particularly with the weather as it is. We are going to be indoors, and so whatever we can do to create that barrier is helpful. And then social distancing and hand washing. These are not new concepts. These are things we've been talking about for 2 years now, and these are things that we should really have sort of figured out and continue to follow to be able to make sure that we are keeping ourselves protected.
Thank you, Dr. Andrabi. So as Eric pointed out in his earlier remarks, and as we all know, meanwhile, as we brace for the potential impact of Omicron, the state is very much battling a Delta fueled surge. Hospitals across Wisconsin are full. There's been reports of patients being turned away because the hospital they want to go to is too full and having to drive maybe even hours for care. Dr. Andrabi, where do things stand right now for ThedaCare in terms of capacity?
Unfortunately, it's not looking good, and I don't think it's looking good for anybody across the state or even across state lines. Our ICUs are pretty much full. We have, last count, we had about 63 COVID patients in our hospitals, which is a big number for us in the region. The number of people, 2 days ago, we had 9 patients in our emergency room that had to be boarded because we didn't have any beds available within our hospitals. You can't call out to anybody else to help because they're all in the same situation, right? So the only way to sort of help this situation is, one, we get vaccinated so we have fewer people coming into the hospital and emergency rooms. 2, the other issue that's happening is that it's really becoming more and more difficult to discharge patients from our hospitals as well, because a lot of our nursing homes do not also have the capacity to be able to take those patients. So it's a backlog, and not only does it affect patients with COVID, it also affects all the other patients that we have to take care of with strokes and heart disease and cancer diagnoses and diabetes and all of those kinds of things that you can think of. A lot of us are also deferring surgical procedures and cases. I know we've done that at ThedaCare on a case-by-case basis because we just didn't have the ability to take care of those patients within the hospital walls. And the other compounding factor is a lack of the people that we need to take care of people. As you may know, there has been what we call the Great Resignation that has also happened in healthcare over the last year or so. Somewhere between 15 and 18% of people have left healthcare. And so it's not about the physical capacity of having the bed, it's making sure that we have the people that can take care of the people in our community. So going back to the basics and doing the preventative work on the front end is extremely important to manage the capacity within our hospitals.
Thank you, Dr. Andrabi. Eric, how are things at Froedtert? What percent of your beds are occupied by COVID-19 patients, and what percent of these patients are not vaccinated? You're still, Eric, you're still on mute.
You know, it is not a Zoom call without not being coming off of mute. So I had my quota there for the day. Much like Dr. Andrabi said, we are at full period at Froedtert Hospital. We're just above now running about 12 or 13% of our hospital beds. When we look at some of our community facilities, though, that number gets up to 30 and 40% of their occupied beds. And in the ICUs, you know, we have 33 of our 100 and some odd ICU beds are COVID patients. Roughly around 88% of our COVID positive patients in-house are unvaccinated. At Froedtert Hospital, given what we do as a level 1 academic medical center, the larger number of vaccinated COVID usually have to do with their immunosuppression and some other comorbidities that are significant here. Overwhelmingly, I believe in our CMO, Dr. Truitt, hopefully I get this number right, those folks still tend to walk out. If we're talking the different deaths, those are largely the unvaccinated that are there. So much like all the other facilities here, it's really impacting and impeding care for those patients who are not COVID that need the care getting in, because the accessible getting to our beds is just very, very hard.
And is that, I mean, you brought this up in your earlier remarks, is that frustrating for you as a hospital leader, and frustrating for your exhausted providers to care for these patients that, as you mentioned, in many cases, that hospitalization could have been prevented if they had been vaccinated?
You know, yes, it is frustrating, but as all of us on this call know, this is healthcare, and there are many other things that we do as a population that are unhealthy. We know are unhealthy, and we know that ends up driving into a hospitalization. So this is just another one of those. It is unfortunate. It's driving it more and more, though. It's more directly tied. And some of our providers and staff and just everyone do get frustrated, but this is what we have to do. We have to take care of patients regardless.
So in Europe, countries are starting to mandate vaccines, COVID-19 vaccines, and issuing more restrictions for the unvaccinated. Eric, I'll stick with you for one last question, then I'll move on. I mean, do you think that policymakers here, both in Wisconsin and the US, could do more to increase COVID-19 vaccinations?
Well, I think, in my opinion, we, particularly the healthcare industry, and you're seeing it more and more in businesses, are starting to mandate. Speaking for us, I think we had less than 1% of our staff really negatively leave the organization because of the mandate that we did put into play. So we didn't see a large number at all. I mean, as we said here, from the science piece, the vaccination does work. Whether or not others and other businesses feel that they actually need to do that, it works. And so if we're just talking about science and data, then it works and it makes sense. And we do this for many, many other communicable diseases as well. So it's not out of line in some of the other policies that have been put in place throughout history.
Thank you, Eric. Dr. Turney, what do you think? I mean, what more can be done by policymakers to increase vaccination rates and ease this burden on already stressed hospitals?
Just a quick comment on where we're at, because I think although we're all going through the pandemic right now, and I think the hardest part of this is that the Delta surge is accelerating while we're still thinking about what other variants might exist and how they're going to impact our organization, which has already been explained. So, when we talk about capacity, and I think some surprising differences in the numbers, which is why I wanted to comment on that, is, well, first of all, we're at about 75% of our peak of where we were last November. So that is very significant. And like Imran said, the numbers are going to continue to go up when you look at the modeling that we all do. And as a result of that, as we look at staffing and the workforce issues, as we look at placement post or at discharge for post-acute care, there are so few opportunities that we are in a crunch in really taking care of other patients that really need medical care. And if any of you have had an elective procedure, by the time you make the decision to have that procedure, because it's a big deal, it is really important that it be done. And we now are again delaying procedures, delaying screening and other types of routine care because we just don't have the capacity. But the one point that I did want to make is that for us, our numbers of patients who are admitted with COVID are a little bit different. 74% of our patients are unvaccinated. So that means that a high percentage are vaccinated. And unfortunately, that does mean people who are older, sicker, and oftentimes have other chronic medical conditions. But, we're still looking at the data because it looks a little bit different than it does certainly in other parts of the state. But your question around, what do we do about policy? It's hard to do a lot about policy when it's become so politicized. We can continue to share information. We can continue to answer questions based on the science, but we know that there's tremendous resistance to masking. There's tremendous hesitancy to being vaccinated. And as long as we can require the mandate, we have. And like others, we haven't had many people leave the workforce. But when you're in an area of the state where less than 50% are immunized, it's hard to get ahead of what we need to do to really have the impact that's necessary. We remarked, no one thought we would be here almost 2 years now when this started in early 20. And I think most of us understand that this is going to be a while yet before we can start changing our lifestyles and the way we work to what had been somewhat perhaps different or similar to what we experienced pre-COVID. So it's a major shock to all of us, and the workforce is taking its toll, and we need to do everything we can to support them and to support our patients during this time, because this is where we're at, and continue to advocate for what's right based on science.
Thank you, Dr. Turney. Bernie, how are things at Ascension hospitals right now?
Similar stats to what's been shared as far as COVID capacity and percentages. A majority of our admissions are unvaccinated. That's a real stat. It's hard to argue that, and I think that is across the system. I think Dr. Andrabi touched on this. Is in the midst of the pandemic, there was certainly delays in other care, or there were hesitancies out there for people to re-engage with the health system like they did, pre-pandemic.
Mm-hmm.
And I think as health systems, all of us are trying to do as much outreach as possible to get, it's a behavior, right? If you think of preventative care, you think of screenings, you think of annual physicals, you think of, hey, I might have something wrong, I need to get in and see a healthcare provider. That's behavioral. And I think, we've been 20 months into this, and it has changed individuals' behaviors. And I think if everybody, on the call today would think about it, your behaviors on how you access healthcare pre-pandemic versus now have changed. And I don't think it's changed for the good. So I think we have to, reinstitute that awareness and address, some of the barriers that exist. And one is, we know this, that, we have COVID patients in our facilities. We also know there's other needs that are out there. Eric talked about it. There's a lot of needs that are out there. And I think everybody is responding. I would say one of the most impressive things that I saw during the pandemic, and what continues in the markets where we overlap with other health systems, is the spirit of collaboration, the spirit of transparency. And Eric touched on it with his opening. It's, being there for our communities, whether it's response to the pandemic or response to, hey, there's individuals in our communities that might not be accessing care like they did pre-pandemic and really need services and care. We're having to be, the workforce, call it the great resignation. I call it the pandemic of the pandemic, and that's workforce, right? It is true, burnout, people looking for alternative careers outside of healthcare. The last 20 months has been very, very stressful for caregivers. for all of us, but for caregivers specifically. And, workforce is it's a real challenge. And I know the organizations on the call today, certainly Ascension, we have done everything we can to support. It's hard to take away what's in front of us, right? We're dealing with a pandemic. We're dealing with people delaying their care. It's hard to take that away. We're healthcare providers, right? We always lean in and we want to take care of those that are in front of us to take care of. But it is taking more creativity. It's taking more innovation. It's taking more flexibility for our staff. So, we've had to lean on cross-training folks to step up and take sometimes new roles. None of us had screeners before. We all had to find screeners. So we've all had to bring in new types of roles to deal with the pandemic. Those haven't gone away. So I think flexibility, I think innovation, I think leveraging technology are things that we're all having to look for today. I think we were looking at them before, but I think even more now, it's pressing us to be a little bit more creative and innovative on how we take care of our communities and what's in front of us.
And thank you, Bernie. And I just want to follow up on that a little bit. I mean, it was mentioned, I think, by every panelist, just the strain that this is placing on the healthcare workforce, and just what a crisis that is, a crisis within a crisis, a pandemic within a pandemic, as you mentioned. What are, Bernie, what are some of the steps that, and you mentioned some of them, but can you just expound on some of the steps that Ascension is taking to recruit and retain its healthcare workforce amidst this? Some systems have looked at raising their minimum wage. Is that something that you guys have considered?
I think every health system looking at that, right? It's, certainly wage inflation in key roles. We're seeing that across the market. That's no different for, Ascension. I think, really understanding, in the clinical areas where some of the challenges are. Short term, you come up with ways to incentivize the staff you have, to engage with the staff and sort of meet the greatest need. And our associates have been, in the midst of great challenge, right, and great stress, really have been, really resilient. So I think it's a time when leaders and associates really come together, probably more than what you might have seen pre-pandemic. When you're in a time of high stress and high tension, you want to be there for your teams. I know we're all doing that, right? So we all lean in and try to come up with creative solutions. So, short term, I think you're trying to get creative on how to staff and care for the patients that are coming into your facilities, because that's what we do. It is becoming challenging, but we're doing it, and we're getting through it. We're all at capacity, right? We're all at capacity. So we're all feeling that same stress and strain on the system. So you do the short-term things that you can, but that they're not sustainable, long-term. We're all having to lean on outside agency. These are individuals that more than likely are, coming from outside our state. That's not really where we want to be in delivering healthcare, is, third-party agency. So, over time, we have to address that from a healthcare system standpoint. You do it in the short term because you got to provide that care to the patients, but long-term, it's not sustainable and nothing that we want to continue from a healthcare standpoint. Longer term, I really think, and talking to university and college presidents, I really think we need to be a little more intentional and creative on like a deeper pipeline. And I know that term's it's used a lot. We don't have the pipeline's not big enough, but I think it's not. And we've got to figure out what our colleges and universities can do, or our tech schools, and what we need to do, as healthcare systems. So, we're leaning in heavier with more intent around pipeline than we had pre-pandemic, because I think we're going to have to rely on that a little bit, or much more, not a little bit, much more than we have in the past. And the last thing I would say, longer term, is technology, and really enabling and supporting and supplementing, our workforce, right? We have seen other industries Lean probably more effectively. Healthcare tends to be a little slower. And we use technology pretty significantly in the clinical side of things, but there's other ways that we can leverage technology more than we do today. And so, one example would be virtual, right? We all had to lean on virtual, but I think if you look at the stats across the state, you've seen virtual care decline pretty significantly. And I think with more intent, we can long-term figure out a way to supplement our staff with technology, actually support our staff more with technology. And I think, in the end, if we can come up with the right solutions, it'll provide a greater quality of work life for our associates. But I think we're going to have to lean heavier and introduce new technology that probably exists. We may not be leveraging it as effective as we can, or it's going to have to be created. But workforce isn't going to go away in healthcare. Workforce challenges.
Thank you, Bernie. Dr. Andrabi, what do you think are some of the steps that can be taken to address these workforce challenges?
Well, I think Bernie has covered it really well, and I'm sure others would agree as well. I just add a couple of things just to highlight a few things that Bernie has mentioned. I agree with him. First of all, these challenges are not going away. And one of the things that we have been talking about in our organization is, we are not going to be able to hire out of this situation. So let's just put that truth out there, at least from our perspective, and then say, okay, then what has to be true? And so a couple of things, I completely agree with Bernie's thought process around leveraging technology. I think healthcare in general has sort of been not so embracing of the technologies that are potentially out there, that accelerate our work, that enable us to really be at the top of our license, where everything is not a task that a person has to do. Where we can leverage artificial intelligence and machine learning, for example, to understand pattern recognition and what is a big one and what is a small one, and where do I have to intervene and where I don't have to intervene. Where we can potentially understand prioritization. So we are looking at some of those things to supplement and support our team members to think about how to use technology in their favor, so that not everything has to be done by an individual, because you have to think about it. The other thing is we are also focusing on, in the longer term, how to redesign work. And so, we've had, prior to COVID, in healthcare, there was a design of, what do the nurses do, and what does a tech do, and what does an LPN do, and what does, and so on and so forth. So we are challenging ourselves to have that conversation to say, if this is true that a lot of people are not going to come back, then how do we have to redesign our work to meet the needs of our community and the needs of our mission, and still be able to get people to the top of their license? So that's work that we have moved into as well. One of the things that we specifically and intentionally did during this time period is that we were not going to lay off or furlough anybody, and that required us to think about, as Bernie said, innovative ways of thinking about our work and how did that need to be done. And so creating a pool of people that were flexible to be able to be deployed in multiple different areas, so that we could help each other out and support the work that had to be done. Another thing that we did a few months ago is we required every leader in the organization to actually go and work at the bedside. So I had the pleasure of doing that as well, not as a physician, but as a support individual, working under a CNA, actually, who was a great teacher to me and helped me think about how work had to be done. And that was done for two reasons. One, for leaders to really understand what our people at the front line were going through over the last 600 plus days. And then to be able to show our support that, we can be there to support you to do this work in this time of great impact that people are having from a physical health perspective, from a spiritual health perspective, and just emotionally and socially as well. So those are some of the things that we've been doing and thinking about both in the short term and the long term with respect to the workforce.
Thank you, Dr. Andrabi. Dr. Turney, hospitals are asked to do a lot, from direct patient care to population health to increasingly public health. As workforce resources continue to be strained, are there certain things going forward that maybe hospitals have to look at taking off their plate? I mean, what are some community partnerships or other strategies that are going to be important going forward as we continue to manage this?
Like others have said, Tim, and thanks for the question, there really has been a major shock to our workforce. And there is really no quick fixes. I think everybody is talking about how do we redesign the care delivery process and how do we supplement that with technology to really advantage us so that we can do a better job in patient care. But as I'm thinking through this, and you think about just technology, which has been mentioned, we were sort of kidding each other internally when we were talking about some new technology. And it seems that every time we bring in new technology, it doesn't lessen the number of people we have. It actually increases the number of workers. So we're trying to figure out how to leverage the technology to use less workforce and make sure that people are, working at the top of their license or their training. So I think one of the things that we're going to have to think about as we model care delivery going forward is really the payment systems. I think there's no shortage of good ideas. I think people in every health system are wrestling with this and doing things that are very creative and very innovative. Yet the complexity of our payment systems in the United States right now, in the multiple schemes that exist, really challenge us to do what's right, move the patient to the right side of care, have the care provided by the appropriate type of clinician. And until we can figure out some balance there, it's going to be really hard for us to move forward. For example, if the opportunities that were created during the pandemic to get reimbursed and paid for services that had not been paid for in the past, particularly telehealth, if that changes, we're going to lose a huge opportunity that we had to really do better care for our patients, reaching out to them over long distances where they don't have to travel during the middle of the winter, and having an opportunity to have a closer touch with them, whether it's with a physician or the clinician, a nurse, or a staff person. So I think as we move down this journey and have to address the workforce issues, we also have to address, and we do have new models of care, we must have support from the different payment schemes to really support that. And if we don't, it's going to be hard to break out of these legacy systems. And, we can't stop doing what we do because of the pandemic, obviously. We need to keep smart growth. We need to, hire staff. We need to acquire or merge with other systems to really better reach out and touch those patients in the community that needs care. But the last point I would make is that the community is critical. If we don't involve our community in these projects, since most care doesn't happen within our four walls, as has been stated, we're not going to be successful. We need to work with public health, which needs to be a core piece of what we have going forward. We need to work with our faith-based groups. We need to work with our WISE and other community hubs where there are opportunities to help people who have food insufficiencies, who don't have transportation, who in many circumstances don't even have broadband. So the community is really key. And I think all of us are really understanding how to reach out better and engage the resources that exist and create a coordinated path so that our patients do get the best care that they need.
And Dr. Turney, to follow up on the finance piece of that, are you seeing in the midst of this more momentum to change how healthcare is paid for? And you mentioned a couple of points, but what are some specific changes that you'd like to see in terms of how healthcare is financed in our country?
Sure, thanks. I think a couple of things. Unfortunately, because we have a provider-based plan, we have been able to implement some innovative and creative care models that others are starting to be able to implement because policies by the payers are changing. And just our home recovery care program, where patients are admitted to the hospital in their home, and where they are extremely comfortable. They have high satisfaction rates, but we know that not only do they get good care, it frees a hospital bed, but they also have less cost to the payer, less cost to the patient, and really high quality care. So again, I think we're starting to see some of those shifts. And I know that will continue to happen. But it's a challenge when you have multiple different payers with multiple different constraints on the way they do cover the services that we need to provide. Virtual healthcare is another one. I mean, a lot of our visits were telephonic because many people in our service area do not have broadband service. If that were eliminated, I know that there are many, many patients, those with congestive heart failure, those with diabetes, those with chronic lung disease, moms and dads with children at home who are acutely ill would not have been taken care of until potentially something much more serious had occurred. So there are many things that can happen. And my hope is that as we continue to march down this journey through the COVID opportunities that have presented, that we will see some changes that will really benefit the way we can take care of patients.
Thank you. Eric, I saw you nodding your head earlier. What shifts, what are some of the shifts you think are underway in terms of how healthcare is paid for, or some of the shifts you'd like to see underway to change how healthcare is paid for?
Well, I think everybody in this call, even before COVID, would want healthcare payment, how it's paid for kind of shift a little bit there. But I think the real point there is on the telemedicine and the virtual visits, and keeping that going and paying that, bringing that up to a little higher, if you will. There are costs with that. It's a different type of care that's being delivered, but there are resources needed. They just may be a little bit different. More virtual care may also help with some of the types of resources that are needed. I'm sure many of you experiences, there's a real shortage in MAs across in our private offices and clinics that room patients. Well, if you're doing it virtually, you may not need an MA, but you do need even more and more technical assistance to help both the patient and even the provider connectivity. Those are different approaches that can happen. And so when you're talking about the reimbursement aspect of that, understand, I'm not sure in that environment how much different the cost of care really is. It may be even more expensive, maybe a little bit more convenient, but at the same time, there's still that cost that is there. I think it was Dr. Turney, you said it before, the more we do innovative things, it seems like more resources are needed to actually get that, and until we learn how to be efficient at that as well.
Do you think on the telehealth piece, some states, including Illinois, have at least for this short-term period mandated that telehealth visits are paid the same as in-person visits? Is that fair? I mean, is that something that policymakers should look at to require that telehealth visits are reimbursed at the same level as other visits?
It helps if they do that. If there's that mandate and they're paying it the same level, then that you're incentivized now to have that televisit, and that can be just a little bit different, create a little bit more access potentially to it. So I'd be in favor of that, and that's also to continue the catalyst towards evening that payout going forward, and greater adoption down the road.
Thanks. Dr. Andrabi, what has the pandemic meant for pay for value efforts? I mean, is this accelerating these efforts, or amidst everything, is it causing some just to press the pause button on that for now?
That's a great question, and it'll be a good question to ask other folks as well. I think so for us, and then I'll go into the general comment. For us, we have been down this path of declaring that we want to be a population health organization, and so not to be in traditional healthcare delivery. And for that, being in the pay for value world and moving down that path of really looking at the total cost of care, improving outcomes, improving the experience, and also thinking about appropriateness of care. So, and Susan talked about this as well, where does the care need to occur? And if it can occur in the home, as she mentioned, okay, let's figure out how to do that so that we can create capacity on the inpatient side to be able to take care of other things. And so we have continued to accelerate down that path ourselves and being a little disruptive. But what has been said is really true, is are the payers thinking about this in a different way as well? Are we really thinking about the continuum, or are we thinking about episodes and fragmentation, right? So much of what healthcare has been about the really old model of everything has to be done face to face, and let's waste 3 hours to do a 20-minute visit, and we're going to pay you only when you do that. And you asked the question earlier, well, why shouldn't it be the same if you can do it through telehealth? And so it's not about telehealth or face-to-face health. There's a space for both of them. The question is, what's appropriate? Right? What can be done in that setting and you get paid for that, and what has to be done in a face-to-face setting and you can get paid for that as well. But what we are not doing so much that we need to be doing more of is, how do we manage the totality of the health of a population, whether it's an N of 1 or an N of 100,000 or 1 million? And then how do we make sure that we are not necessarily nickel and diming healthcare from a unit cost perspective, but we are really thinking about the total cost? And so I may have it be appropriate for somebody to be seen by a primary care physician more frequently, but reduce their ED visits and reduce their inpatient admissions. And that's appropriate. And how do we get paid for doing that kind of work? So no simple answers, unfortunately, but that is the pathway that I think if you look at the pandemic, if we were in that kind of a model, we would all done really well. And has been said, when the folks came out and said, well, you can do telehealth and you're going to get paid for it, but just look at the adoption rate that happened because of that, right? So these are all good things for our communities. It actually enables us to live our mission and really improve the health and well-being of our communities. And the more we can move in that direction, and I think we are all wanting to go there. So if other stakeholders can come alongside and help us get there, we can actually improve outcomes, we can reduce the cost of care, and we can actually improve the experience for people in our community.
So what, Dr. Andrabi, what's holding that back? If everyone wants to get there, what's holding that back?
The payment system. The payment system doesn't come alongside doing what is right. And that's not an indictment on anybody. It's just, let's sit down and have those conversations and be real about it, right? So particularly for some of us who don't have that payment system within our own health systems, then we are dependent on the third-party payer to have that discussion. And our incentives need to be aligned around our community and making sure that those are the outcomes we are looking for together.
Bernie, let's shift to you. A part of this too is, of course, that there's a limited amount of dollars out there. What more can health systems do? What's the responsibility of health systems in decreasing healthcare costs?
Well, I want to go back to what Susan says and then Dr. Andrabi, because I think it does come back to the payment system. And I think when we look at innovation, the payment process or payment structure does lag innovation, right? So, I mean, we've been talking for years about, value creation. Think about in the 80s and the 90s, right? various forms to try to drive innovation in healthcare. When the payment system lags innovation, it's hard in a fixed payment system. We all get paid a fixed fee. So I think fragmentation is an issue that we need to overcome, right? And I also think that trying to address this whole idea around care model change, right? Care model change and then accelerating the payment models to support that, right? We all today, every health system on the call today, we have individuals sitting in our facilities that we cannot get out to the next level of care. We all get paid on a fixed fee, right? And that fixed fee is based on what has been determined as a length of stay. And we're doing our jobs with case managers and our physicians and our team to get individuals ready to go to that next level of care. But the capacity is not out there in our community. Yet there's the payment model today doesn't pay us for the care that we have to continue to provide in our facilities. It's non-existent. We're absorbing all that cost internal. We continue to provide care, right? We can't place them. Or to Susan's point, hospital at home, which, you know, I'm aware that Marshfield is doing it. We're also piloting in other markets across Ascension. And that's another area where the payment model hasn't caught up. You think about it, had we had that in place, how that could have helped us significantly address the pandemic, right? I mean, there is care. I mean, we're pretty advanced as a healthcare delivery, right? I think it's the will to want to lean into these alternative forms of care and figure out a way to, you know, to fund them and pay for them. In the end, I think it can actually improve healthcare access, healthcare delivery, you know, and improve quality and the overall experience for patients and families, right? We're all seeing the stress, and you think about it, healthcare in the home. If we can figure out as healthcare delivery systems a way to provide that, why are we not getting behind that in a big way? Why are we not getting behind that if it can be proven? It's not every DRG that's in a hospital that can be done. But as Susan knows and others know, there's a lot of care that we could provide in the home if we had the right care model in place. Definitely have to have the right care model, right? Certified to be able to do that. And then the payment model to actually support that, right? Many of these today are all pilots, right? Or they've been given, special project or reimbursement through various states or payers. But I think that's what's going to have to accelerate is that type of payment system and innovation.
Thank you, Bertie. So just to follow up on that, I mean, so what is the responsibility of health systems to decrease healthcare costs? I mean, is it the job of the health system just going to keep push forward these models and work with the payment systems to come along, or what is the responsibility of a health system to decrease healthcare costs?
Well, I can chime in and let my colleagues, I think if you look back, I think we have leaned in, right? I think most of us are involved heavily with health plans. We're in different types of value payment, right? We're trying to make sure that, our seniors are getting in for their, Medicare well visits, right? To identify, again, no delays in care, right? You think about it, delays in care increase healthcare costs, right? So we're trying to do those things on the front end, all that preventive care. And I think that we have revamped the delivery system, given the current payment model, to take costs out, right? We've all looked at our supply chains. We've all looked at workforce and, how to manage our workforce. So, and we've all partnered and are willing to partner more, I would say, with payers around value, right? But, everybody's got to lean in both sides, right? But I think there's more to be done with willing participants, both on the payment model redesign, but also the incentives. Eric talked about it, just aligning the incentives. I mean, a perfect thing is virtual care, right? Look what happened. And it was good. It created so much more access in the system. People could get, it's more consumer centric. It really ramped up. It started to change behavior. So we saw a lot of positives come out of that move. You know, we cannot take that away. We've got to maintain those gains, and enhance that model of care and the reimbursement that goes along with it. Because if we peel that back, then it's going to really deter future innovation in telehealth and virtual care.
And I agree with Bernie saying. The other piece of this very much is just the whole post-acute care modeling, right? The payment in that aspect, the number, the accessibility. So it is the care at home, hospital at home, but also just getting someone to a skilled nursing facility, a post-acute facility. In these times with COVID is almost next to impossible. And so the driving the costs are up on the acute side and the post-acute side because there's no access. If we can align incentives, even change the pay structure out there where for greater pay and greater reimbursement in the post-acute, we can appropriately transition patients to the right level of care, which ultimately is a lower cost. You can stay in an ICU bed here at $2,000, $2,500 a day just for basic resources, or you could transfer it to an appropriate post-acute for half of the cost, even if the reimbursement is a little bit less. I mean, that's what we have to really start looking at and pushing the payers and then the accessibility, the number of available post-acute beds in Wisconsin and in the communities. That's a dire straits right now.
And that is an issue that has been going on for a while now. These patients stuck in hospitals across the state, unable to be discharged. Would a better payment system be the solution to this? I mean, you still need people in these nursing homes to take care of these patients. And talking to nursing homes across the state, that's a big part of it too. Is they're just not. They don't have, like hospitals, they don't have the staff to take care of these patients, and so have to close wings or sometimes even close down.
Yeah, it's the reimbursement there. I may not be as high enough to hire the staff that they need for that or the appropriate level of staff. It's a lot of this. And you ask about what we can do to further drive down costs. Understand COVID is very much a public health crisis, right? And in the public health system in this country, more focus has been on the acute side. So now is it up to the health systems and the healthcare side to kind of push the public health piece is what we really have to look at and address as well.
Dr. Turney, Marshfield has expanded to a number of communities in recent years. This fall announced an agreement was in place to acquire Dickinson County Health System in Michigan's UP. As we talk about what the future of how care will be delivered is, how about the future of where that care will be delivered? I mean, what is your vision at Marshfield? Is it in hospitals? Do hospitals look different? I mean, what's your vision of the future of where care will be delivered?
I think I'd go back to a couple of things that I've already said. Healthcare has advanced, and we know that there are many things that can be provided safely and effectively outside of the home. And I'll give one example, just our heart failure clinic. Most large integrated systems do have a heart failure clinic. Most of that care is provided remotely through phone consultation, through virtual visits. Rarely does a patient have to come in to be seen because they can monitor their vitals, they can get their weights checked, they can have their labs drawn by home health. And at the end of the day, you have a model of care that shows a markedly decreased cost, but more importantly, less admissions, less readmissions, less complications, less ER visits. So when you look at the value stream, which is something that we're talking about, the value is there. The problem is, I think the ecosystem, and probably Bernie knows this as well as anybody, the ecosystem of each market is dramatically different types of providers, different types of healthcare institutions, different types of payers. So to pull things together in a way that we can have a real strong influence at the state or national level is just really tough, because we're all doing really good, important things and have figured out ways to move down that value change, both in the care delivery and in the payment model. So I think for, to your question, what can we do when we think about advocacy? It's really coming to terms with issues that are common regardless of site and regardless of payer, and long-term care, post-acute care, getting paid better for a DRG, because we're boarding patients with COVID for a long period of time because facilities don't have the capacity to help us because they're full or because they don't have the workforce to meet those needs. So I think the power really is coming together on those things that we can all agree to are important, and then we can look for ways to solve them, because the nuances of care is still pretty local, and also the ecosystems vary so dramatically. So we have to think big and really solve those problems that are amenable to maybe, if not a one-size-fits-all solution, but pretty close to a one-size-fits-all solution. And they're out there. And I know many of us are working on them, but we're going to have to continue to push, because at what happens is, it's the patient that gets put in the middle and has the risk of not getting what they need. And when we talk about health inequities, that should be front and center all the time for us.
Excellent. Thank you, Dr. Turney. So we are quickly running out of time. We've talked about a lot. There's a lot we didn't get to. But just to kind of sum things up, I have one final question for each of the panelists. And Dr. Andrabi, let's start with you. What would you say are the biggest healthcare trends that are going to be driving healthcare in the years to come? If you had to pick one or maybe two, what will be those biggest trends kind of taking up the most of your focus going forward? We have about 3 minutes left, so a minute tops per panelist.
So really quickly, I think healthcare disruptors, and don't be looking for the big ones, look for the small ones. All right. Technology, and then moving from the inpatient to the ambulatory. Mm-hmm. So I'll leave it at that. A lot more can be said there, but in the interest of time.
Excellent. Thank you. Bernie, what do you think? What are going to be some of the biggest trends?
You may hear similar themes here, right? I mean, we're all being impressed with the same things, but I would say, care model redesign, and all the things we already talked about, right? The reimbursement that needs to support care model redesign and innovation, and certainly technology geared at. So we think about it as a system, but I think it's technology geared for consumer-centric care. The consumer wants the healthcare system to change as well.
Great, thank you. Eric, what do you think?
I agree with what was said here, particularly about the disruptors, and not the big disruptors. It's the small ones that you'll see entering the market, where they're going to cater more to that real high convenience, that what I'll call the Amazon type mindset. Whereas, can I get what I want right now, right quick? And then once I do that, how can you connect me, if I need to somebody face to face? And that'll be small things that are entering the market, along with all the other technology, all centered around how do we change the care model delivery.
Great. And Dr. Turney, we'll give you the last word. What are going to be some of the biggest trends facing healthcare in the years to come?
Certainly everything that's been said, but one thing that wasn't mentioned is the focus on the healthcare consumer. I believe that is going to explode. And we know that COVID did, this whole debacle really has been a human tragedy, and it has exposed many of our faults and inequities in our health system, but also in our society at large. So I think for us in healthcare, we need to do better. And the place we have to start is by thinking about, or actually by not thinking about financial models or even technology. I think we have to start by asking our patients truly what they value, what they need, what they want, and how do we make that happen? And then I think we can build healthcare around the patient. That's a good place to start.
Excellent. Well, thank you so much. Thanks to all of you for taking some time out of your valuable time to be with us today. And thanks for all that you do. Thanks to everyone who tuned in today's discussion. And thanks to our generous sponsors for making this event possible. Thank you.
Thank you.
Nice seeing all of you again.
Stay safe.
Get us back,
Sure.
Tim, when we can see each other face to face.
Look
Right.
forward to it.